Today we're going to take a quick ride through the immunoproliferative disorders and tumor markers. Now, if you've taken hematology and chemistry, which most of you have, you're going to have seen a lot of this before. So I'm going to stop at the very important parts, but we're going to go through the things that you've probably seen a little bit faster. So starting with the immunoproliferative diseases, usually these are a malignant growth of lymphocytes, the leukemias and lymphomas. We can also have some plasma cell disorders as well that is sometimes linked to the leukemia type of problem. We can also have a genetic alteration in a cell. We have a transformation or a progeny which does not respond to normal cell growth signals at all. Some of our risk factors for these disorders include having an immunodeficiency. Okay, you could have been born with one. You could have acquired it through having chemotherapy or something like that. You could have had an autoimmune disease. You could have genetic susceptibility like Down syndrome or something. You could have a chronic infection such as H. pylori and hepatitis C, or even some viruses like Epstein-Barr virus, human T-cell leukemia, or lymphoma virus. First, we're going to start with leukemia and then move on to lymphoma. Leukemia, as you've learned, can be myeloid or lymphoid, and it starts in the bone marrow. That's how we differentiate leukemia from lymphoma. Leukemia starts in the bone marrow. Lymphoma is more of a lymph node, right? But with leukemia, it can spread to the lymph nodes, the liver, the spleen, the central nervous system, and many different places. Occasionally, we see other cell types with tumors arising in the bone marrow, which are also called leukemia. The two lineages are myeloid and lymphoid. So myeloid, we see monocytes, granulocytes, mast cells, RBCs, and platelets. Lymphoid, we see B cells, T cells, and natural killer cells. These things can be acute or chronic. Hematology, you've heard us talk about acute lymphocytic leukemia. We have chronic lymphocytic leukemia. And there's quite a difference as to how they present themselves. So acute is usually aggressive. It grows very rapidly, and we see many immature leukocytes in the blood. Chronic is very slow. It takes a long time to progress, and it's much more difficult to treat. We see a lot more of the mature leukocytes in the blood with that one. So some of the types that we see, one of them is acute lymphocytic leukemia. This usually occurs in children. And actually, our neighbor little boy next door was just diagnosed with this year, is my son's friend. And he has to take a couple years off of school, actually. And it's something that it's usually kids. And when I worked in the hospital, it was always kids. I remember when I had, oh gosh, it was probably about 15 years ago, I went to the pediatric unit as a tech to get some blood from a child. And the child was in the room with the parents, and the parents were trying to explain to the physician what happened and how they found out he had leukemia. Well, it was interesting because the little boy, the parents said they would set the little boy down. He's about 18 months old. And he would start walking, and he would fall to the ground and start crying. They'd put him back up. He'd fall to the ground and start crying again. And they couldn't figure out what was wrong. They took him to the pediatrician. They ended up x-raying his legs, and his bones were broken in his legs. Reason being, the bone marrow expanded from the rapid progression and multiplication of those progenitor cells, and it caused the bone to actually crack, and it broke his bones from the inside. So that's kind of how they noticed that little boy had it. So very, very common in kids, okay? Chronic lymphocytic leukemia, we tend to see it over the age of 50. Next, we'll look at lymphomas. These are mature lymphocytes in the organs of the lymphoid system. We see them in lymph nodes, spleen, the mucosal-associated lymphoid tissue, and the thymus. They begin as a solid tumor, but we can see them in the blood. In the lymph nodes, those are anywhere. Most often the chest, neck, and underarms. It spreads to one node to the other in a chain. Usually they don't skip a node until it's the late disease. It rarely metastasizes, but it can in the very late stages, especially this Hodgkin's disease. So with this Hodgkin's disease, we see Reed-Sternberg cells. This should ring a bell from hematology as well. These are the cancer cells in the Hodgkin's disease. It's a bilobed nucleus that has an owl eye appearance. You can see the two eyeballs almost in here. The 5-year survival rate is very high. So stage If you find it in stage 1 or 2, 90%. Stage 3 is 80%. Stage 4 is 65%. So this is another cancer, kind of like ALL is pretty treatable too, that wouldn't be the worst one to get if you had to choose one. Next is plasma cell dyscrasias. This incidence increases with age. Black patients have a 3 times the incidence over other nationalities. Males are greater than females, and if you're a male, you have a worse prognosis. What happens is plasma cells replace normal cells in the bone marrow. We see a decrease in all of the cells. So we get anemia, thrombocytopenia, and leukopenia. We also have bone pain and a hypercalcemia issue from that bone involvement. There's also an increase in plasma volume. We have a decrease in the RBCs, WBCs, and platelets. Anemia gets worse, leukopenia gets worse, cytopenia does. And we see an increased amount of immunoglobulins too, and that can lead to rouleau. That is the stacking of RBCs on a slide. So they all stack up on each other. It reminds me of Rolos. If you ever had that candy, that chocolate Rolos, all in a stack. Well, rouleau is a stack of red cells. And we can have increased plasma proteins, increased calcium. We see kidney damage. And with multiple myeloma, we see an M spike present on the electrophoresis and the Bence-Jones protein present in the urine. Next one is Waldenstrom's Macroglobulinemla. This one's called a lymphoma rather than a myeloma. It's present as a solid tumor in the lymphoid organs. We have enlarged lymph nodes in the spleen and some bony lesions on occasions. We have a very high infection rate because we don't, there's an inhibition of infections because we have such high IgM levels. We can see anemia. And with that, some bleeding problems are seen as well. So there's high levels of IgM, and it alters the platelet function. The macroglobulin, think IgM being a huge immunoglobulin, it's kind of where that word comes from. Next is light chain disease. We see Bence-Jones proteins in the urine, multiple myeloma. Renal damage occurs. We have heart, liver, and gastrointestinal involvement. And long-term survival is rare. If you survive a year, you have about a 20% chance of that. Heavy chain disease does not produce or attach to a light chain. The chain is not full length, and it's similar to lymphoma, more lymphoma than myeloma. Bone lesions don't occur, but we have tumor cells usually located in the mucosa of the small intestine. Next one's IgA heavy chain disease. This one's more often found in the Middle East. Very young stages that we find it in the patient. And we have heavy chains in the serum or urine. Sometimes when you do a biopsy. But on the serum protein electrophoresis, we'll see a decreased gamma globulins and an increased alpha-2 and beta peaks. So now we're going to move on to the tumor immunology. Some of this will hopefully look familiar to you as well, because I did talk about this in your clinical chemistry course, specifically Chemistry 2, Week 1. So, an introduction to tumor markers and oncology. Oncology is a branch of medicine devoted to the treatment and study of tumors. You may have heard of a carcinogen, which is capable of altering host DNA. You may have heard of people having a tumor, which is a proliferation of abnormal cells that produces a mass, rather than a reaction. You can have a benign or a malignant tumor. Very important that you know the difference. A benign tumor is encapsulated, slow growing, doesn't really spread, right? Malignant, it can increase and accumulate, invade healthy tissues, it can metastasize. Metastasize means move around, and reoccur. Here I've added sarcoma. Sarcoma can arise from the mesoderm, that means it's from the skin. All right, so let's look at the epidemiology of this. Cancer in adults, the most common one in men is prostate, lung, and colorectal. Women, breast cancer, lung, and colorectal. Cancer in children, the most common is ALL. Then we see brain cancer, CNS, central nervous system, that is, tumors and lymphoma. And the risk factors for having a tumor would be smoking, poor diet, age, and where you live. So environmental factors play a role. If you've ever seen Erin Brockovich, I believe she went on, there's a movie about this attorney who went on this rampage to try and sue or figure out if all these people were getting sick from these certain power lines that were in an area. You can have a genetic issue and even viruses that can cause some problems as well. So we have some stages of this carcinogenesis. First is the initiation. This is irreversible mutation, okay, involving proto-oncogenes. Then you've got a promotion stage. This is where growth enhancement happens to pass on the mutation to other cells. After this, it starts to progress. This is the development of tumor heterogeneity for metastasis, and we see drug resistance. I added in apoptosis. I think we've killed this word to death throughout the MLT program, but this is the process at which the cells normally die off. So what's a proto-oncogene? These act as the central regulators of growth. The oncogenes are the mutation of those proto-oncogenes, and there's the genetic. They are the genetic target for those carcinogens that we are exposed to. The mechanism of action, we see point mutations, translocations, and gene amplification. And we can have the viral oncogenes. We've talked about Epstein-Barr virus. There's even the human papillomavirus that we hear a lot about. So what does our body do to defend against these things? Well, we've got our T lymphocytes, our natural killer cells, our macrophages, and our antibodies. We also test for a whole list of them in the medical laboratory, and we've covered these in chemistry already, so I'm not going to go through each of these individually, but if you don't know them, make sure that you make note cards with them because these are going to show up on a quiz and exam, okay, in this immunology course. Now, of this list, all of these are used to monitor therapy effectiveness and disease recurrence, okay? We don't go and draw every patient for a CEA to see if they have colon cancer. We would have other issues that would lead the doctor to find that they have colon cancer. They would be doing a CEA to follow that patient as they go. So if they start chemotherapy, a CEA level is 100. Hopefully, with chemotherapy, that CEA level starts to drop down to 80, down to 70, down to 60, down to until it's negative, right? Because we don't want to have that tumor marker in our blood. Now, the one exception is PSA. PSA is the only tumor marker that is routinely used as a screening test. Okay, the rest are used to monitor therapy effectiveness and disease recurrence. So how do we treat these cancers? Well, we use chemotherapeutic agents, okay, to help stop rapidly dividing cells, which is why your hair falls out, because you're killing those rapidly dividing cells that your hair grows out of, so they stop growing because you killed them with chemotherapy. It's a good thing for the tumor marker or tumor cells because those are rapidly dividing as well. Unfortunately, so is your hair. We can have some effects of drug-induced immunosuppression. We could get infection because we're killing not just hair follicles and tumor cells. We're also killing white blood cells. Okay, so that can cause an immune suppression, and people can get very sick. We have some recent advances with cancer. They're starting to find vaccinations that can stop those rapidly dividing cells, and sometimes gene therapy. So you're going to see more and more coming out in the news with those types of things in the near future. That concludes our section on immunoproliferative diseases and tumor markers.